Today we will examine the budget request for Indian Health Service, IHS. I'd like to thank and welcome Rear Admiral Michael Wiaki, the new acting director for the Indian Health Service, appearing before us today. I think we all recognize that the head of IHS is a tough job, and it's a critical one. It's certainly critical for us in Alaska. I know for Senator Udall, it is equally important and critical in his state. But recognizing that, again, we appreciate the role that you play here today. Director Wiaki is accompanied by Rear Admiral Chris Buchanan, the Deputy Director for IHS, Gary Hartz, the Director of the Office of Environmental Health and Engineering, and Elizabeth Fowler, the Deputy Director for Management Operations. So we welcome all of you. The IHS budget request for FY 2018 is $4.7 billion for programs within this subcommittee's jurisdiction. This is a decrease of $300 million, 6% below last year's enacted. By comparison, other agencies within the Department of Health and Human Services were reduced by an average of 18%. So I think when you compare it on balance, it is important to recognize that I think there was some effort to mitigate the impacts on the IHS budget relative to other agencies. I am pleased to recognize that the budget does provide full funding for contract support costs by maintaining the indefinite appropriations language that I first included in the FY16 appropriations bills. I think that this has helped to provide a level of certainty for tribes as well as protecting other IHS programs. What we were seeing was effectively robbing Peter to pay Paul, borrowing from other accounts. And while it may have helped one, it was at the expense of others, which I think we recognize was not a good direction in how we meet the government's legal obligations. Now, having said that I support where we are with contract support and appreciating the fact that the cuts that we're seeing within the IHS budget are not as severe as they are in other areas, I am very, very concerned that the budget request does not adequately meet the needs for health care in Indian country. I think we recognize the disparities between health outcomes for American Indian and Alaska Native people combined to the population at large are staggering, just staggering. For example, American Indians and Alaska Natives are 3 times more likely to die from diabetes. The drug-related death rate for Native Americans has increased 454% since 1979 to almost twice the rate for all other ethnicities. Of course, we unfortunately talk far too often about the incidence of suicide. The suicide rate amongst our First Peoples is roughly twice that for the rest of the population. So in order to improve healthcare delivery, the IHS must do a better job at hiring, as well as retaining an adequate number of qualified doctors and nurses. The IHS must also do a better job of maintaining a large facilities infrastructure that serves 2.2 million American Indians and Alaska Natives. And this requires significant resources. We all recognize and appreciate that. Currently, the vacancy rate for IHS doctors, dentists, and physician's assistants is roughly 30%. The backlog of facilities maintenance at IHS hospitals is over $500 million, and this, according to the agency's own budget documents, the average age of its facilities is roughly 4 times that of its private sector counterparts. And I think we recognize that additional resources are not the only answer. So much of this comes down to the quality of the existing workforce. I read, and I'm sure that my colleagues also read, several of the articles that appeared in the Wall Street Journal just last week on July 7th. And I have to tell you, I was horrified, I was sickened, I was mad. There was a whole range of emotions as I read that. Because this is our IHS. These are our facilities that are supposed to care for our First People. And the stories that were detailed were shocking. The deplorable conditions that we see, unfortunately, at several of our IHS facilities in the Great Plains. In one case, a 35-year-old man stops breathing in his hospital room. You have nurses that are responding to the emergency, and they can't find the crucial medical device that is needed to prop open airways to his lungs. And it's a device that should have been stored in an emergency supply cart. It cost them a critical 20 minutes, and later in the internal report, they found that 20-minute delay cost the patient his life. The investigation also revealed that the responding nurses were unfamiliar with how to use the hospital's intercom system or a defibrillator. Basic. In another case, a 45-year-old woman died 10 hours after IHS nurses ignored a doctor's orders to stop giving the patient a powerful cocktail of narcotics. A federal inspection report found that 2 different doctors told staff that they were concerned that the patient was being over-sedated. One of the doctors ordered nurses to stop giving the patient morphine and to remove a patch that dispensed fentanyl. The patch was never removed, and when the patient fell off her bed that night, nurses gave her even more pain medicine, including a sleeping pill and oxycodone. And as she fell into a catatonic state, coughing, frothing at the mouth, nurses failed to alert doctors. She's later found dead. I will have both of these articles from the Wall Street Journal from July 7 included as part of the record. But again, I think when we read these as lawmakers, and certainly as one who has oversight of IHS through this Appropriations Subcommittee, but as one who serves on the Indian Affairs Committee, this is not acceptable. And I know that oftentimes they say when it's not about the funding, it really is about the funding, but it's about the funding. It is about the quality of the individuals. It is about the ability to get good people in. It's about making sure that that the infrastructure is maintained. We are not doing right by our Native peoples, and this must be remedied. Last year, we had the acting director of IHS, Mary Smith, before the committee, and I asked what the agency was doing to fix the problems at the Great Plains, in the Great Plains region, at the Pine Ridge, Rosebud, and Winnebago hospitals, all of which were mentioned in these Wall Street Journal articles. And she indicated at the time that the agency was committed to doing, quote, whatever it takes to deliver quality care. Well, here we are. I do believe that the agency is aware, does understand, is sincere in its desire to fix these problems. But we can't move from year to year and continue to see a degradation in the services. The Winnebago Hospital has not received certification from CMS. The Rosebud Hospital, the Pine Ridge Hospital are still operating under system improvement agreements with CMS. So it's one thing to come before the committee and say we're going to try to do better, but we have to have better results, and I think you know that. In the FY17 omnibus appropriations, the subcommittee provided an additional $29 million to address problems at these facilities. So I would hope that today we will hear how the agency is allocating these funds, and if there was a shortage, why you did not request further funding for the problems that we have seen in the Great Plains region for FY18. I think, again, the situation is absolutely unacceptable, intolerable, and we need to have a clear and specific plan as to how to address it. So I now turn to my ranking member for his comments, and then we look forward to questions from the panel. All right, responses from the panel, questions from us.